Bismillahirrahmanirrahim. Ladies and gentlemen, my topic of presentation is ideal treatment for prosthetic valve thrombosis. Valve replacement with prosthetic mechanical or tissue valve is the only treatment for many diseased cardiac valves. Thrombosis of prosthetic valve is potentially life-threatening complication. Prompt identification of valve dysfunction with timely and appropriate treatment mitigate the risk of catastrophic outcome. The older prosthetic mechanical prostheses start Edward and the tilting disc were more thrombogenic as compared to the newer third generation bi-leaflet prosthetic mechanical prostheses. This is the picture of bioprosthetic mechanical valve. It is least thrombogenic except in the first initial 3 to 4 months. By definition, prosthetic valve thrombosis is defined as any thrombus near or attached to a functioning valve in the absence of infection, which interferes with valvular function or occludes part of blood flow. This is how the prosthetic thrombosis looks like on the prosthetic mechanical prosthesis. Basically, there are 3 factors responsible for the causation of prosthetic valve thrombosis. The endothelial factor, till the time of endothelialization, or about 4 weeks, thrombosis is higher during this period. The second is the hemodynamic factor. Localized area of turbulent flow causes endothelial trauma and damage to blood cell, with resultant release of ADP, which promote platelet aggregation. And third is the coagulation factor. Insufficient anticoagulation, mitral and tricuspid positions, hypercoagular state, presence of associated atrial thrombus. The bioprosthetic valve are at risk of thrombosis till endothelialization. Mechanical valve have a lifelong risk of thrombosis. While tricuspid prosthetic valve is more for thrombosis due to low velocity of blood across it. Mitral valve have high risk of thrombosis than the aortic prosthesis due to low velocity of blood across it. Now, in order to set target INR after mechanical valve replacement, 2 points needs to be considered. One is the prosthesis thrombogenicity. In third generation bi-leaflet valve, the thrombogenicity is very low. And the second factor is the patient-related risk factor that include the mitral and tricuspid valve replacement, previous history of thromboembolism, presence of AF, mitral stenosis of any degree, and left ejection fraction less than 35%. So, due to low thrombogenicity of bi-leaflet valve, we keep INR 2.5, and in the presence of risk factor, we keep INR around 3. The incidence of mechanical valve thrombosis is 0.1 to 5.7% for left-sided mechanical valves and 20% for right-sided valves. In case of bioprosthetic valve, it is around 0.03%. It may be an incidental finding on routine TOE, or PVT may present with events of thromboembolism, 25% of the cases, or in case of obstructive prosthetic valve thrombosis, there will be hemodynamic problem. So, patient in obstructive PVT present with dyspnea, heart failure, signs of heart failure and cardiogenic shock with muffled heart sounds with or without new murmur. While thrombosis of the right-sided causes right-sided heart failure. The onset of symptom may be progressive or acute depending on the rate and degree of stenosis or regurgitation. The investigation required include a fluoroscopy for detecting the leaflet motions, transthoracic echocardiography for measuring gradient across the valve as well as the degree of regurgitation if present. In PVT, mean transfemoral gradient greater than 50% is considered significant. Esophageal echo is a gold standard for detecting the size and extent of thrombus and helps to differentiate penis from thrombus. And multi-detector CT is a complementary tool used in selected cases in which if TOE findings are equivocal. Management of mechanical valve thrombosis include anticoagulation, thrombolysis, and surgery. Surgery may be declotting or redo MBR. The indication of anticoagulation include small size thrombus with recent onset and mild symptoms. So in anticoagulation, we give IV unfractionated heparin to achieve APTT of 1.5 to 2 times. It is monitored clinically and by echocardiographically. The indication for thrombolysis include failure of anticoagulation, small size thrombus, right-sided PVT, large size thrombus if surgical intervention is contraindicated. Thrombolysis protocol includes short protocol and long protocol, and there are varieties of thrombolytic agents like plasminogen, streptokinase, and urokinase in variety of doses and duration. Successful thrombolytic therapy should be followed by warfarin and IV heparin until INR is 3 to 4 for aortic valve prosthesis and 3.5 to 4.5 for mechanical mitral valve prosthesis. Patient in whom thrombolytic therapy is partially successful presents a challenge. Options include both subcutaneous unfractionated heparin twice daily to achieve APTT of 1.5 to 2 times the control, and warfarin therapy with target INR of 2.5 to 3.5 for 3 months. Initial success rate of thrombolysis is around 70 to 80%, with risk of embolism, stroke, and bleeding around 5%. Contraindication of thrombosis include any bleeding, presence of large mobile thrombi, severe hypertension, cardiogenic shock, and major surgery within the last 2 weeks. Surgery may be declotting or redo MBR. It's recommended for patients with severe symptoms and left-sided thrombosis, regardless of thrombus size. Emergency surgery is recommended if the thrombus is larger, more than 1 centimeter in diameter. The rationale for avoiding thrombolytic therapy with large thrombus is the marked increase of thromboembolism. Surgical treatment has a combined risk of death and stroke of around 9%. This is the ACC guidelines 2020 comparing fibrinolysis with surgery. The factors which favor surgery includes readily availability of expertise, low surgical risk, contraindication to fibrinolysis, recurrent valve thrombosis, NYHA class 4 symptoms, large clot, presence of LA thrombus, if there is concomitant coronary artery disease or valvular disease, or possible presence of pannus, and finally the patient choice. This is the flow of chart taken from ESC guideline 2021. Note that in case of non-obstructive thrombus and in the presence of thromboembolism, if the thrombus size is greater than 10 millimeter, then surgery is considered. Fibrinolysis will be done if surgery is contraindicated. Similarly, in case of obstructive thrombus, if patient is critically ill, surgery is immediately available, then we will consider surgery. If it is not available or if it is of high risk, then we will consider fibrinolysis. Now I am going to share experience of prosthetic valve thrombosis at AFIC and NIHD. The first study was conducted by Cardiac Surgical Department in 2014, comparing the two surgical procedures, that is the declotting and the redo MBR. It was a retrospective interventional study, and 36 patients were included in this study. Majority of patients were in class 3 or 4 symptoms, and 36 patients, 28 patients underwent declotting, and 8 patients underwent redo MBR. 26 patients had partial stuck valve, while 10 patients had complete stuck valve. The endpoint of this study showed that the mortality in redo MBR was significant, around 50%, as compared to declotting, which was around 7.14%. So the outcome study suggests that declotting is recommended over redo MBR in the absence of any prosthesis failure or the presence of pannus, because of better outcome in terms of mortality. This is another study conducted by the Cardiology Department in 2018, thrombolytic therapy in PVT. It was a prospective cross-sectional study, and 51 patients were included in the study, underwent fibrinolysis using SK, And mitral valve thrombosis was present in 40 patients, and aortic valve thrombosis in 11 patients. 21 were in low functional class, while 29 were in high functional class. 8 patients presented earlier within 3 months, and 43 patients presented late. All the patients had wide leaflet mechanical prosthesis. 36 patients had partial stuck valve, and subtherapeutic in INR was found in 37 patients. Complete thrombolysis was achieved in only 47% of the cases, and failed response was in 27%, while incomplete was in 25% of the cases. The mortality was around 25.49%. Limitation of this study was the lesser use of TOE. The outcome of this study suggests that urgent surgery should be carried out once fibrinolytic therapy is observed. Fibrinolytic therapy is failed after 24 hours. This is just a case presentation of failed thrombolysis. This is a 25-year-old gentleman had a mechanical valve AVR in 2012. He had a poor compliance for anticoagulation for the last 1 year, history of stuck valve 1 year back, thrombolized successfully, reported again with stuck valve in May 2022 with NYHA class 4 symptom. And T showed moderate to severe AR with mean gradient of around 20 millimeter of mercury. This is the pre-thrombolytic fluoroscopic image, and thrombolysis was done, but sorry. And this is the post-thrombolytic image showing again the restricted movement of the disc. So this gentleman underwent emergency declotting, and he had an uneventful post-operative recovery and was discharged from hospital on 5th post-op day. So finally, in conclusion, prosthetic valve thrombosis is rare, but it's a life-threatening condition. Significant morbidity and mortality warrants rapid diagnostic evaluation. The risk of valve thrombosis appear to be higher in the first 3 months after implantation, and TOE should not be underestimated. It's a very important diagnostic tool for estimating clot burden, and if low functional class, anticoagulation should be considered. If the functional class is high, then either thrombolysis if surgery is high risk. Following the restoration of thrombus and hemodynamic, long-term anticoagulation should be added to prevent recurrent valve thrombosis, and serial follow-up is needed. I thank you very much for your patient listening.
Sir, at the end of the session.